Hi there, my name is Hannah Scholten. I'm a physical therapist and the clinical rehab supervisor at UFHealth Rehab up at Wildlight. I'm going to be talking to you today about the role of physical rehab in chronic pain management. So just to give you a little bit of an agenda here, I'm going to start with just giving you my background and some background in the epidemiology and neurophysiology of pain. And then I'll talk a little bit about interdisciplinary chronic pain management, functional restoration programs versus medical pain management. And then I'll spend a good chunk of time talking about physical therapy concepts in chronic pain management, including acute versus chronic, active versus passive, graded exposure, and individualized treatment. And then I'll also spend some time talking about screening and assessment tools as well as interventions for chronic pain management. And then finally finish with chatting about some barriers to treatment and when to refer. So just some information about my background. I spent about 7 or 8 years working in Chicago at the Shirley Ryan Ability Lab, formerly the Rehab Institute of Chicago, or RIC. So I was working in their chronic pain management program there, which is a full and part-time program for adults and pediatrics, very immersive program. With a full team, including PT, OT, pain psychology, biofeedback, vocational rehab, physiatry or PM&R docs, and nursing and administrative, an administrative team. So a big collaborative team. We all really work together to help each of our patients with their common goals. And so now I've been with UF for about the last year, and I'm up at, like I said, the Wildlight Clinic as the clinical supervisor, and we have both the pediatric and adult outpatient rehab practice up there. Really excited for the opportunities there. So just some background and statistics here about pain in the US. So I'm sure you've all seen or heard similar numbers being tossed around in recent years in the setting of the opioid epidemic and chronic pain becoming a bit of a hot topic in healthcare. I know right now it's hard to see past the pandemic we're in the midst of, but chronic pain does continue to impact millions of Americans every year and remains to be one of the leading costs of healthcare dollars in the range of hundreds of billions. So I thought this was a really shocking statistic near the bottom here that yearly costs for chronic pain are more than cancer and diabetes combined. So it really, makes you wonder how much of that is for nothing. If you consider just in your little bubble of being a medical practitioner, how many chronic pain patients have you had who had years of medications or workup or injections or often multiple surgeries, and yet they still continue to suffer? And so we have those direct costs that I had just gone over, but you also have to consider the indirect costs of chronic pain. You have loss of identity, loss of a job, sometimes even, marriages fail or relationships fall apart, loss of friendships and social engagement. These people, yes, they have lost wages and are spending significant healthcare dollars, but they're also losing their identity. So in response to this epidemic and really just a need for a better gold standard for these patients, in 2016, the NIH released the National Pain Strategy, which outlines a plan for reducing the burden of chronic pain in the United States. So this strategy acts as a guide for our medical system on how to approach management of chronic pain using high quality and evidence-based standards. Just some things to point out here that I've highlighted. It really outlines that this needs to be integrated, interdisciplinary, and patient-centered, right? And this seems like it should be obvious. We should be centering our care around the patient who is in pain. We should be collaborative in doing so. So the NPS has several objectives. If you've ever taken a look at it online, it's very long, and there's several subgroups of topics. But just to kind of summarize, I think a few of the more important takeaway messages here. First, that chronic pain is a biopsychosocial condition, right? This is something I'll discuss a bunch more in just a minute, but I think it's really fantastic that the NIH has an appreciation for this concept. And that we need to be continually improving our ability to effectively assess and treat this population, right? Clearly, or we wouldn't be spending billions of healthcare dollars each year with attempts to treat it. You know, if treatments are ineffective, those need to be weeded out. This is something that we did in our pain program. Our physicians, the first thing they would do is, you know, discontinue or replace any pain medications that have been ineffective for patients, replace them with other alternatives such as rehab tools, you know, that can be potentially more effective for quality of life and functional restoration. So let's just briefly review and differentiate pain clinics versus functional restoration programs. And I think we understand as medical practitioners the difference here, but I think the general population sometimes has a misunderstanding of the difference in these two things. I think pain clinics, right, are used to describe what is just a medical practice. So just physicians, typically anesthesiologists or physiatrists, who offer pain medications, modalities, interventional procedures such as injections. And these types of clinics are absolutely effective for certain populations, but they do provide a bit, like I said, a bit of a false narrative for those patients who are maybe suffering from chronic or high impact pain. We'll get more into this in a bit, but I think here it's just important to recognize that this is what the vast majority of pain clinics in the country offers, more of this medical practice, rather than something that's truly interdisciplinary, like where I work in Chicago, and there's a handful of them across the country, but where these programs are more appropriately referred to as functional restoration programs. And I think the big takeaway here, the big takeaway here is pain clinics, I think the primary intention there is to reduce pain, right? Well, functional restoration programs, while they do work to reduce pain, their primary focus is to improve function and to manage pain. So let's get into the role of PT or rehab in all of this. So I've gotten this question more times than I can even say. This is the #1 question I'll get from patients at the start of our program in Chicago. Still one of the first questions I get when patients come in to see me in the outpatient clinic here with chronic pain issues. They say, you know, I've done lots of PT. How is this going to be any different? And that skepticism is absolutely warranted, right? They've probably had years of PT already, or maybe failed PT elsewhere. So why would this be any different? Why is it going to be successful if it's never been before? PTs are PTs, right? We all have kind of the same training and all practice under the same professional definition. So how is this going to be any different? So the answer is, in some ways, it may not be any different. You know, we do all come from the same general background of education and training. But we tell our patients, I think if we're treating chronic pain, that there are some conceptual differences in the way that we approach their treatment. So after working in this kind of setting and working with this patient population for several years, I was able to kind of categorize these concepts into 4 main subgroups: active versus passive approach, graded exposure, individualized treatment, and laying the foundation. So we'll get into these now. So I think in order to begin taking any approach with this population, your patients need to first have a solid understanding of the basics of acute versus chronic pain. And again, I know all of you know the difference between acute and chronic pain, but I'm going to just explain this in the way that I might kind of explain it to a patient. So let's just talk about the definition by timelines first. Acute pain generally refers to a short window of time, right? Hours to days to weeks after a tissue injury. While chronic pain, by definition, does kind of vary, but generally refers to a matter of several weeks to months or even years after a tissue injury. So that acute phase is often called the inflammatory phase or healing phase, because generally when we have an acute tissue injury, you see inflammation or swelling, which is just a sign that your body is healing itself. The swelling is from your body sending fluid full of healing cells to that site that's needing repair. Right? Think about when you sprain your ankle. And I'll point out here, if you're having this conversation with a patient, I think it's important to use an injury example that's fairly benign, like a sprained ankle or a stubbed toe, rather than something like breaking a bone, because to someone with a very sensitive or heightened nervous system and chronic pain, you want to avoid using that noxious language that could be triggering to them. So what happens when you sprain your ankle? It swells up. It's probably pretty painful to move and pretty weak for a while, and you may see some discoloration. And as that inflammation resolves, so does the pain. Now, it's important to note that acute pain is an important protective mechanism. If you're like me and have grabbed the hot handle of a pan after it's come out of the oven more times than I'd like to admit, the acute pain response is what tells your brain to tell your body to quickly pull your hand away. And without that response, you keep your hand on that hot pan and continue to burn your skin. It's also important to know that acute pain is generally felt in proportion to the extent of injury. Okay, so if you stub your toe, you may feel some pain for a matter of minutes. If you sprain your ankle, like the example I gave before, that healing phase and acute pain is likely going to be felt for more like a matter of weeks. And if you have surgery, you may have pain associated with that healing phase for up to 12 weeks. But in all of these examples, regardless of the varying length of healing time, the pain will generally resolve as the tissues heal. And then by contrast, chronic pain means pain that is felt a longer time after an injury, as in several weeks to months or even years after that window of the acute healing phase. And although pain remains, you no longer have a tissue injury because we know that tissues have a healing timeline and they have already healed by this point. So the question that we're asked most is, if my tissues are healed, why do I still have pain? Pain means I'm injured, right? How many times have we all heard this reasoning from our patients? And this is something that's, as we know, been extensively researched for decades, and it's only recently becoming more widely understood. And the answer is fairly complex, but what we now know is that chronic pain is no longer just an issue in the tissues. Pain felt beyond that window of healing is not just because of what's physically happening in your body or biologically or physiologically, but also because of various emotional, situational, and contextual factors. So things like past experiences, beliefs about pain, situational circumstances, other life stressors, sleep or lack thereof, coping mechanisms or lack thereof, cultural background. Right? So these are things that we now know. So again, just returning to definitions, we now know that while acute pain is very much a response to a physical injury, chronic pain is an emotional experience that is associated with actual or potential tissue damage, both physical and emotional components combined with other aspects. So there may no longer be a tissue injury in the setting of chronic pain, but it's important to also validate to patients that there absolutely are physical manifestations of chronic pain. I won't go into this whole chart here, but I think it's just a good reminder and good reference for what happens to our body's systems in the setting of acute versus chronic pain. So in acute pain, on the left-hand side column there, all of our systems respond in kind of that fight or flight manner. Our muscles tense up, our heart rate elevates, we get this sympathetic response. Our systems go into healing and protective mode. When that pain persists, these systems all persist as well. So over time, we get all sorts of maladaptive changes in every aspect of our body's functions. We have maintained elevated blood pressure. We have generalized inflammation. We have difficulty focusing. And we have compensatory muscle activation patterns and breathing patterns, hypervigilance. We have poor parasympathetic function, so poor digestion, poor sleep, hypersensitivity to pain, and so on. And so these are very real systemic changes that you'll see in the setting of chronic pain. So this is what leads to what we refer to as many vicious cycles of pain, right? So we have pain, we avoid movement, so we get muscle tension and guarding. When we try to move, again, it's more painful because we've been still, and so we avoid moving more, and it just feeds into itself. And note that we can replace muscle tension and guarding here at the bottom right. We can replace that with all sorts of other things, like here I've listed sleep disruption, stress or anxiety. These cycles aren't just physical. And in time, when that pain system and all of its manifestations are left on, we see the development of what we call central sensitization. It's not just an issue in the tissues any longer. Our entire nervous system is impacted by all of these things that we just talked about. And so what we have is a generalized hypersensitivity. The way I explain this to patients is someone who hasn't experienced pain the way that you have for the time that you have, they may stub their toe or have a stressful day at work and can almost disregard it. It's felt briefly, but it's relatively nothing to worry about, and that sensation passes. Their nervous systems can kind of brush it off. But for a nervous system that's become sensitized after such a long time of feeling pain, even relatively small things like stubbing your toe or an inconvenience at work can cause a whole flare-up felt for days. And it's not just changes in how you feel or interpret things, but we know now that this central sensitivity is associated with actual chemical and structural changes in our brains. All sorts of MRI studies in recent years have shown us just how this can happen. And the good news is these brain studies have also shown us that it's very much reversible. Our brains are very plastic. Our clinic in Chicago, some of our physicians and researchers actually for the last few years had done fMRI studies. So we were imaging patients' brains before and after our program. And they found significant, in just 4 weeks' time, our programs were 4 weeks long, significant changes, increases in brain volume. So this was found in places like the thalamus, the hippocampus, and amygdala, and other parts of the brain. And those findings were also associated with significant improvements in the standard outcome measures that we were giving our patients. You know, these patients were also rating themselves as feeling much more improved. So correlates there. Pretty cool stuff. So when your patient asks, so you're saying it's all in my head? The answer is yes, right? If we didn't have a brain, we wouldn't have pain. So now that your patient has a better understanding of acute versus chronic pain, let's get into some of these conceptual differences of how we approach this. So active versus passive pain management, starting with passive pain management. And I would encourage you all to quiz your patients when you're having this discussion with them. Ask them, what do you think are passive approaches to pain management, right? So these are going to be things like massage, chiropractics, hands-on physical therapy, even ice or heat, injections, medications, surgeries, right? Anything that's being done to you is passive on your part. Your role in that treatment is passive, right? And so what kind of effect do these tend to have on our pain? Your patients will probably answer, they feel good. They give you immediate relief, right? But how long does that relief last for, right? You take a pill, you get a massage, what have you, you feel great, but that kind of wears off within an hour, within a day, within weeks, if it's something like an injection, right? So we have to go back and do it again, right? So here's the deal. These strategies are not wrong to do. These are not wrong approaches to pain. In fact, they're absolutely appropriate for some patients, for those who have had acute or subacute pain, because those passive strategies, they're designed to get us through that healing phase. Think about after surgery. It's important to move right away. That PT is going to be in your room, getting you out of bed to mobilize you as soon as that anesthesia wears off. But my gosh, you just had surgery, right? So those pain medications, that ice afterwards, those are very important to allow us to tolerate that very important early out of bed activity. But for someone who's in chronic pain, we know that there isn't any longer an acute injury or inflammation that we're needing to work through. And these passive strategies only begin to actually take away from function. The relief is only temporary, so you're having to go back again and again and again, sometimes for months or even years. And now it's costing time and money, and it's not actually providing any improvement in overall pain or function. And so what these strategies have done now is create a physical dependency, right? I'm in a pain flare, so I need to have that injection, or I need my PT to do that thing to me that they did last time, or I need that medication in order to function. So they're depending on someone or something else to only temporarily give them relief. So that's why with chronic pain management, we need to take an active approach. meaning the patient has an active role rather than someone or something doing something to them. And this can be a tough pill to swallow, no pun intended, because these strategies do not often provide that immediate relief that I think so many people are looking for. But over time, they address those underlying reasons why we continue to have pain. Rather than putting that Band-Aid on it, we're going to get down to the reason why you feel it. And slowly over time, these strategies will help to make you more functional and in turn have better managed pain. So what does this look like? First and foremost, this is a hands-off approach to physical therapy. We need to really break that dependency cycle in which patients are relying on someone or something else to fix them and really encourage self-reliance. It becomes our roles as educators to empower. So the goal is to have your patients leave rehab not feeling like they need you as a therapist, right? But rather that they feel like they have the tools themselves to make themselves feel better in the setting of pain. And this doesn't need to take months and months of ongoing therapy. When you keep going and going and going because pain isn't improving, you're only reinforcing to the patient that they need to be cured of their pain in order to measure success in therapy. But that isn't the case with chronic pain. When someone may very well experience some degree of pain for the rest of their life, it's your job as their PT or as their therapist to help them understand that they can still have a fully functional life despite the pain they have, if they have the tools to effectively manage it. And managing it doesn't always mean getting rid of it entirely. So how do we do this? How do we teach our patients to self-monitor and even self-progress exercise or activities? How do we teach them to know what they've maybe, when they've maybe done too much? So I would hear patients say all the time, they come in to PT with a solid, nope, last time I tried PT, I was in bed for 3 days after. Or how can I exercise if I'm in pain? And the answer is through graded exposure. Okay, so by taking into consideration each patient's past experiences, beliefs, emotions, and how those things contribute to their relationship with movement. And start very small, however small you need to in order for that activity or movement to feel safe for that patient. And then you very slowly, gradually go from there. So I like to use the activity pyramid with patients for this. And I found it to be very effective. We used it in our program across all disciplines. And it's really helpful when it's not just coming from PT, but coming from all of a patient's sort of practitioners. So we give them an actual handout, it doesn't look exactly like this, but a handout with an activity pyramid on it. Just some simple reference information. And, it teaches them to better pace themselves. In our program, the OTs can talk to them about pacing. The psychologists can talk about it when they have emotional responses to pain flares. Physicians can use it when they're checking in on patients in their biweekly follow-up sessions, right? So it's no longer just a concept to the patient, but an applicable tool that they have with them and can refer to and use all the time. So generally with this concept, you've got activities that your body tolerates at that green light zone at the bottom. So you might feel a little discomfort or, if you're being challenged in your strength or flexibility, but with that activity, even if your pain does increase just a little, it will resolve after you finish that activity. What you're feeling during it is just that challenge on your body, but nothing that stays around. And in that yellow light area, that next area, that's what we refer to as the flare-up. Okay, so pain might increase in a flare-up by 2 points or more on that 10-point scale, and it might remain elevated afterwards, maybe into the evening or maybe into the next day. And the biggest take home here, though, is that that does not equal injury. Okay, hurt does not equal harm. This is just your body saying, hey, maybe that was a little too much too fast. And so now in the setting of that flare-up, let's maybe pace a little bit more until pain begins to return to its baseline. But just really the big take home there is you're safe and sore. Hurt does not equal harm. And then that red zone at the top, so that would be an actual acute tissue injury. And we really let patients know what this looks like. You're going to have a significant elevation of pain, and that's going to be associated with a drastic and sudden loss of strength or mobility. And then we would have to treat that acutely. But we'd also tell our patients, and this was true then and still holds true as I tell you now, that We never had a single patient experience an acute injury as a result of doing activity in our pain program in Chicago. I think, the reason for that is truly because we're teaching patients to listen to their own bodies and learn these concepts on how to acknowledge what their body is saying and adjust accordingly. So it's important to note that where, activities fall in that pyramid are by no means fixed. Our activity tolerances are fluid and nonlinear. Think about like yourself and the things that you tolerate, based on your own personal circumstances day to day, right? So if you're really lacking sleep or really stressed, you probably feel less capable of doing certain activities. But with an increased awareness and knowledge of these principles, these tolerances will gradually increase. And so you'll start to see more activities that fall into that green category and less activities that fall into that yellow category over time. And I have heard some people say that, when you're treating chronic pain, you shouldn't even talk about the pain. But really, I couldn't disagree more. I think it's good to not focus on it, but rather focus on function. But you simply can't teach a patient to self-regulate if you don't educate them on how to better understand what their body is saying to them with regards to their pain response. We like to tell our patients that rather than the no pain, no gain saying or phrase, we say, know your pain, K-N-O-W. Know your pain to know your gain. Knowledge is power for self-management. So the next big conceptual difference in the rehab approach for chronic pain versus, your typical or traditional PT or rehab approach is that of individualization. And I think we all know this. We always tailor our therapy to patient responses. It's what we're trained to do. But we need to individualize not just to physical responses to exercise, but also consider the non-physical components of pain that we need to tailor for, right? So how do those past experiences or beliefs contribute to their response in session? How does this patient learn best to promote carryover or compliance? What's meaningful to them? What kind of environment or time is available to them outside of this clinic, outside of this space? So even though it makes sense from a biomechanical or physiologic perspective to prescribe a certain exercise, that exercise is not going to be effective if your patient has a traumatic or negative relationship with it. So these are definitely things to consider. Prescribing a home exercise program needs to be the central component of your treatment sessions. Your 45-minute or so therapy sessions once or twice a week are not going to be what gives these people help in the long term. What's going to help them manage their pain and become more functional is what they do that other 166 hours of the week. I firmly believe that if I put my hands on a patient in a session, I better be able to show them exactly how they can recreate what I just did for themselves at home. And it's so important to make sure that you're prescribing, that what you're prescribing is constantly reviewed and upgraded and modified, which also means paring down. I always make sure that my patients have a very concise and clear list of exercises or stretches that are not only physically doable and effective, but also meaningful to them and logistically doable outside of the clinic walls, right? Space and equipment, time in their day, work schedule, right? So are these things feasible to be doing every day? Or can some things be done maybe as an as-needed basis only? What can be tossed out? What's no longer effective or necessary? So when you're considering compliance for a lifetime of self-management, it's better to leave your patients with 3 exercises that you know they will do because they're meaningful, doable, and effective, rather than, 15 exercises that nobody's going to have time for. I wouldn't do 15 exercises every day if I was told to, right? We're busy human beings with all sorts of other priorities. So it's important to have an open dialogue, determine what works and what doesn't for your patients to promote that long-term adherence. Now, moving into screening and assessment for the chronic pain patient. I get the question a lot, asking what screening tools should be used to determine if a patient is at risk for chronic pain, or if there's someone who may benefit from a more immersive functional restoration program. And honestly, I don't have a great answer. For one, there are lots of yellow flag questionnaires out there, but no great literature to support any given one. And in my experience, all of the patients we treated in our program were very obviously already determined to be a chronic pain patient who was needing our sort of intervention. So they were already there and enrolled to begin, so we kind of have that answer already. So I think for the most part, we can use our best clinical judgment to determine when a patient is just generally not responding to treatment the way you would typically expect. And I think as clinicians, we also have an ability to recognize when a patient's pain may be less physically mediated and have a greater psychosocial component that we aren't able to address as physical therapists alone. But this is a list of assessments that I do think are helpful to determine if a patient's pain is more related to those psychosocial factors than to a more biomechanically driven pain. And it's important to point out that all but one of these is they're assessments that really should be conducted by a psychotherapist, not a physical therapist. So the one that we can do as physical therapists is the TAMPA. So this measure is reliable and validated to determine a patient's fear associated with movement. And it's one that I used with every single patient with our program in Chicago. So we, have patients fill this out at eval, at their progress note, and at the end of the program, or for any follow-ups. I would suspect that if you're in an outpatient setting and you're suspecting that your patient's progress may be limited by psychosocial barriers, this would be a good one to use. And it's also very appropriate to use your typical regional specific outcome measures with this population. So in addition to the TAMPA, maybe do something like a region specific outcome measure, at the eval, at the progress note, at the follow-up, discharge, as well as the PSFS with 3 patient identified functional goals. So the patient specific functional scale is a really great way to objectify someone's subjective experience with movement due to pain. In addition to written outcome measures, functional outcome measures are really useful in assessing this population. The assessments that I would recommend are the 6-minute walk test, the 5 times sit to stand, or the tug. The 6-minute walk test is another one that we did with almost every single patient in Chicago in our program. And I think it's a really fantastic way to get just like a big picture of this person's function. As far as strength and range of motion measures go, these can and should be taken with a very big picture lens as well. So that would be, manual muscle testing for just those major muscle groups, quantifying range of motion simply in terms of nil, min, mod, severe loss, rather than down to the degree specificity with a goniometer. Functional strength screens, like quality of double leg or single leg squat or sit to stand mechanics, can also be useful in determining functional strength versus isolated muscle strength or weakness in these more functional muscle groups, as well as just general postural observations to determine any postural functional weakness. So the reason I wouldn't recommend taking those goniometric measures, as I had mentioned, with this population, and certainly not any joint play measures with the spine or the extremities, the reason is this: you need to consider that these patients have likely been experiencing this pain for months, years, or even decades. And at this point, their bodies have generally compensated or adapted. So at this point in the game, degrees of motion, joint play, or specific isolated muscle strength testing, we're not going to be getting the information we need from that. And even if we do see a change in degrees of motion with this population, it will likely be very small. And for someone who's coming in because their pain is impacting all the aspects of their life and preventing them from participating in their life roles, what does 5 degrees of motion change in that? What we need to focus on instead is function. And that's why we use these written outcome measures and functional outcome measures, because since we can't really objectively measure function, the best possible way to objectify therapeutic change in this population is through measurement of their perceived function or perceived ability or limitation. Pain is a perception, right? So it only seems logical to do it that way. So we take these outcome measures along with subjective screening into consideration. We can't successfully help a patient if we don't meet them, really where they are. So now let's get into some interventions. So what do we do with these patients if we aren't putting our hands on them? The answer is a lot. In fact, I often find that there's never enough time with these patients. In Chicago, I was seeing patients for 3 or 4 one-on-one hours per week. And, there's never enough time, even though I'm not spending good chunks of time doing mobilizations or manual therapy. So first and most obviously, pain neuroscience education, right? So now this is not something that's done in isolation, but I think it's best provided in small intervals, kind of interspersed into both individual and group treatment sessions. So repeated reinforcement of simple principles is the best way to promote carryover and integration. And you have to remember that for the most part, these patients, especially those with poor health literacy or general poor literacy, if you dive right into it before the patient's really ready, you may as well be speaking in another language. I tend to not actually get into any of this education until at least the second visit, because it just allows for the patient to do the talking at the evaluation. There's so much trust that needs to be established with this population, and patients oftentimes have a very long story to tell. And so just actively listening and letting your patient feel 100% validated in their pain experience creates a more open and trusting therapeutic relationship. From my experience, it can certainly take kind of biting your tongue at times in the eval, but if you try to interject any of these concepts while they're trying to explain their experience to you, that can be interpreted as, you don't think my pain is real, and can very quickly turn into a defensive mode situation. And that's really not the foot you want to start off with these patients. But as far as reference materials or resources go, I think all of Butler and Mosley's material is the best out there. If you haven't had the opportunity to take one of their courses, I would highly recommend it. The NOI website is just rich with information and resources. Our program messaging was very much based on their explain pain messaging, and we use their analogies, and I still use their analogies in teaching and educating patients. So from my experience, this material is the absolute best with regards to speaking in ways that your patients can understand. But really, no matter what concepts or material you choose to use, whether it's from another author or just from you, my biggest piece of advice would be to keep it simple. It's easy sometimes, I think, to forget that what information may seem second nature or common sense to us is absolutely unfamiliar and abstract to others. So always check in with the patients and assess how much they're truly understanding. So the next intervention I'll talk to you about is laying the foundation. Okay, so when a patient has acute pain or injury, their physical therapy will likely be targeting just that one specific area of the body affected. But when pain becomes persistent or chronic, we have to really take a step back. Remember the biopsychosocial approach. We're treating the whole person, no longer just the body part. So with these patients' home programs, you really should be working on, what you should be working on is just generally laying the foundation or really retraining the body from the bottom up to teach them how to move in a healthy way again. So the way I explain this is that in our bodies, we have different types of muscle fibers or muscle groups. We have superficial muscles, the ones that we can feel, like our biceps, right? We can feel it move our arm. It's our mover muscles. They move joints or segments of our body, just like your bicep moves your arm from straight to flexed. So these muscles are designed to perform quick, high energy tasks. They move, they turn off until they're asked to move again. So they're the sprinters, okay? Then we have those deeper muscles, the ones that we can't always feel or see because they sit so close to our spine. So these ones are designed to support our bodies, to literally support our skeleton against gravity. So they get their energy differently. They're designed to be on all the time, just kind of at a low level, anytime we're upright, to hold us up against gravity. So these muscles can be described as the marathoners. They may run a bit slower, but they can run much farther. So what happens in the setting of chronic pain? Think about what a patient may look like in pain. What postures do they take on? You see compensation everywhere, right? When you ask a patient what makes their pain worse, how often is it when I sit or stand or walk for too long, or when I get up from this position to that? So postural assessment shows elevated rounded shoulders, forward head, tension everywhere, right? So what happens is that those sprinter muscles are doing all sorts of protection mode work. So it's allowing those deeper muscles, those marathoners, to go on vacation. And over time, that leads to learned misuse, further overcompensation of the sprinter muscles. And so these patients have a really hard time maintaining postures, right? Because those sprinter muscles aren't designed to be holding our bodies up. They're designed to just move quickly. So when they're asked to do the job of a marathoner, this leads to more increased pain and tension. And it also means we have less deep support of our joints, which in turn causes increased pain in the joints as well. So once that foundation is solid, we really work on those deep muscle activations and isolations. Once that foundation is solid, and this can take several sessions to weeks to really successfully retrain those deeper muscles to isolate, then you can begin to build on it. So this would look like slowly adding in stabilization exercises and lying, then moving to more dynamic stability exercises, then transitioning to more functional or weight-bearing exercise, and then ultimately getting to the patient desired activity. So on top of having this be a main focus in patients' home exercise programs, also incorporate it into other functional activities. So you want to make sure that these aren't just kind of meaningless exercises that they're doing in isolation, but help them to understand, oh, okay, so that's why this muscle group is important. And that's why I'm doing this, because when I do this movement or this activity, these muscles are working, help them make that connection. So, at the end of therapy, I think patients often ask, what do I do next? As if there's like a handbook of what exercises to continue to progress with for the rest of their life. But what I always tell them is that first of all, there is no handbook. Do what you enjoy. Get back to just doing whatever exercise you have been doing before, whatever exercise it is that you're wanting to do. But just keep this foundation in mind and keep up with these simple exercises every once in a while to maintain that muscle memory and ensure that you're using those right muscles, those deeper muscles, with whatever activity you choose to do. So cardiovascular endurance, this is another huge part of active pain management for chronic pain. I could spend another hour just talking about cardio exercise for chronic pain alone. There's definitely, I think, a continuum of patients that are at either sort of at extreme end of the chronic pain spectrum, those who are full-on avoiders and those who push through at the other end. So not a whole lot of patients that fall in the middle of that road in my experience, right? Either patients are in pain, so they avoid moving altogether, become deconditioned, or they ignore their pain and push and go through it. And I'll say, in my experience, there are far more folks that are in that avoidance end of the spectrum. And these patients tend to be very physically and cardiovascularly deconditioned. Now, cardio exercise for a patient who's been sedentary for a long time due to pain, that can be scary. Like I said, I could talk to a patient for just an hour straight about, cardio exercise, why it's going to be part of rehab, and really why it's not so scary if you really give them all the information about how to monitor it and progress it. So just like with any other activity, it's so important to take a graded exposure to this exercise, to cardio exercise. So in our program, we would have patients make it a goal that by the end of their 4 weeks, they would be doing 20 to 30 minutes of continuous gentle cardio. And we base this on the ACSM guidelines. But we also made it very clear that we do not expect that to happen on the first day or even the first week. We just want to see that they're making progress towards that goal. Okay. You start with what's comfortable. And for some, that might mean literally just orienting to the equipment, not even getting on it, but standing next to it and seeing how it works. And then the next step might be sitting in a seat and gently pedaling for just a few minutes. And then maybe taking a break and trying it again. Okay, so it's really important to integrate this cardio exercise into your treatment sessions and also offer ways that they can begin to integrate it into their days outside of the clinic. Because like I said, there's a lot more time spent outside the clinic than in it. Teach your patients how to gradually progress their cardio efforts and how to listen to their body, both their pain response and their cardiophysiologic response, so that they have a knowledge of how to and when to progress themselves. So general strength and mobility obviously is going to be part of rehab, whether it's for chronic pain or anything else. And I won't spend a whole lot of time getting into this because it's pretty self-explanatory, but of course, this is a big part of our treatment because patients who have had pain will likely have some underlying weakness or tightness as well, just because of disuse and compensation. So part of our treatment is addressing those underlying issues. But again, just like with laying the foundation, it's important to point out how these exercises or stretches have a functional application, right? So what are your patient's biggest functional deficits? How does strengthening this muscle or that, or stretching this body part or that lead to an improvement in those tasks, right? Make it meaningful. You can see in this picture here, this woman is sweeping underneath that chair, and she's using shoulder mobility and strengthening there to stabilize. She's using, maybe we're working on stretches to improve her trunk and hip mobility in order to do that task. We're maybe doing quad strengthening or knee and ankle mobility training for getting down onto her knee into that position, right? So there's a functional application of what we're working on. So neurodynamics is another big part of this rehab approach. Neuro is our nervous system. Immune system is also controlled by the CNS. So immune system has a huge role in chronic pain, right? Immune cells have a role in plasticity, cognition, pain, and learning. So if you have a maladaptive or unhelpful immune response, when the nervous system perceives a threat or danger in a body region because of chronic pain, right? What does that response feel like? So that sends these danger signals and just heightens this, sensitive nervous system. So why do we mobilize the nervous system? To improve blood and oxygen delivery and decrease that sensitivity. And how do we mobilize it? There's all sorts of different ways. We can do stretches that are gentle stretches that do elicit some pain or some neural tension, but starting again with what feels healthy and gradually moving into increased tension. And over time, you do get a reduction in that, dural tension or discomfort with tight nerves. Cortical disinhibition, or what we call localization training. This is probably not heard by many. This is something that we did really commonly with our patients, and there have been a lot of research done with some practitioners at the Rehab Institute of Chicago at the time that I was there with this. But it's fascinating, and it really is using just kind of a 2-point discrimination to determine a brain's, accuracy of a depiction of what's happening in our body. So I could spend a lot of time going through this, but basically you're looking at the brain's accuracy of the painful body part or an area near the painful body part, comparing left to right, affected versus unaffected limbs or affected versus unaffected body parts. It can be done as just an assessment initially to see if there is kind of a blurriness of that map of the brain on one side or another, on the affected side versus unaffected. And if there's less than 80% accuracy, that tells us this is something we maybe can work on. And so we use the exact same kind of process that we did for the assessment as now a treatment. And we can do that repeatedly, and there's ways to progress it and make it more challenging. And really what you're doing is you're treating the brain. You're bringing that body focus, or that body map of the in the brain back into focus. And doing that can help to have more accurate signals, a more accurate message, and over time desensitize that sensitive nervous system. So desensitization, right? So localization is often done in conjunction with some level of desensitization as well. So this comes in many, many forms. It can be tactile desensitization, starting with a soft or light touch in very short intervals, progressing to maybe something like wearing socks or shoes or pants, maybe holding something or gripping something with a painful arm or hand. It can also be done with regards to activity tolerances. So going hand in hand with graded exposure, right? So it may be that patients have triggering environments, whether it's light or sound or sitting at a work computer. So if you start with very short intervals of gentle exposure to those environments, and then integrate active pain management strategies and pacing principles, you can allow for a gradual increase of intensity or interval of time. And remember, this can be a very, very slow process, and it will really do more harm than good if you process or progress through it too quickly. So use that activity pyramid. Let the patient learn how much is too much, and ultimately learn how to self-progress and modify. Some patients with CRPS maybe haven't tolerated wearing a sock or a shoe or maybe even pants for several months or even over a year. So really take that into consideration, that this could take several months' time to get back to just even wearing a sock for 30 minutes at a time. And everybody will be different because everybody's circumstances and nervous systems are different. So graded motor imagery is a very specific form of desensitization in which you use imagery and visual feedback to help change the way that the brain thinks about movement and sensation. I think this is another one that tends to be done too quickly, maybe too many things at once, and that can make the brain actually a bit more overwhelmed as a result. I think mirror therapy should rarely be done as the first intervention, and I think oftentimes therapists will jump straight into it. So in some cases that might be okay, but really in most cases, this can be very overstimulating and more than a sensitive nervous system can really handle. But generally speaking, you want to start with implicit motor imagery first. So that would be like laterality training. You can use flashcards for this, or you can also use maybe magazine photos of body parts. And then you transition into explicit motor imagery. Okay, so that would be watching or imagining movements and postures with increasing complexity. What can be helpful initially is to have patients actually visualize their loved ones performing movements, because just thinking about loved ones taps into those feel-good parts of the brain, and it can help to dampen that pain response. And then finally, once patients are able to tolerate both implicit and explicit imagery, then you can begin to introduce this mirror therapy. And this is a way for patients to not only visualize performing a task with their affected limb, but actually trick their brain into them doing it without pain. It's very fascinating and very effective when it's done correctly. So really graded motor imagery, these are designed to activate that both the sensory and the motor networks without triggering that protective pain response. It's utilized for relearning cognitive and planning components of functional movements. You really want to do this daily to promote that neuroplasticity and restore that central nervous system modulation to diminish that pain perception. So postural re-education, this is really going to innately be part of the treatment approach with these patients. Postural tendencies, they reflect not just those underlying weaknesses that we've talked about, but they can also have a situational or environmental context as well. So we can treat those physical components as physical therapists, but remember that there may be psychosocial or situational components that, at play that may be better addressed by a psychotherapist. For example, working through a trauma associated with, certain people or triggering situations. So postural re-education is really about addressing the underlying weaknesses and those deep stabilizer muscles that we were talking about, and reducing muscle tension and guarding in those compensatory muscles. So you really break down the guarded movement patterns. So teaching patients how to restore segmental movement again, rather than, moving in block and guarded all the time. So this just really takes kind of breaking things down, using visual feedback, whatever cues it takes for your patient to feel what that feels like again, to move in a more fluid way. I think sitting on a Swiss ball is really helpful for this. Using a mirror for feedback can be very effective as well. And finally, pacing. So pacing training. So there's that tortoise and hare again. This needs to be a common language for your patients from the start, that pacing needs to be part of the vocabulary every time that you see them. So it becomes part of theirs. And contrary to popular belief, pacing does not mean slowing down or not doing things. In actuality, it allows for more over time because you avoid that crash and burn effect from happening all the time. I always say to patients, if you push through to the point where you crash for 3 days, you have this up and down roller coaster just over and over again. You go up, you come right back down. You go up, you go up, come right back down. And a year from now, where do you think they'll be? The answer is probably in the exact same place they are now. But if you take this very slowly, very gradually, you may only have, you may have small setbacks here and there, but you may be moving very slowly, but you're still moving in the right direction. You're moving up. So now consider where that will put you a year from now. You won't be right here. You'll be improved from here. So sometimes it takes stepping back and really seeing that big picture. And so I have to finish with this because I think this is so, so important for us as physical therapists, rehab therapists, right? That the gold standard for treating high impact chronic pain is with immersive interdisciplinary care, right? The National Pain Strategy outlines it very clearly. Evidence suggests it very clearly. As PTs, we are only one piece of the puzzle for the most effective outcomes. We can absolutely use these strategies that I talked to you about. And in all honesty, the barriers are often a lack of acceptance of chronic pain, a lack of readiness for change, and significant psychosocial barriers. And I know the hot topic, the hot button topic in the last couple of years has been for psychologically informed PT, which is great, right? Although I think we should be bringing that humanistic approach to all of our patients, regardless of pain. But we also have to remember what's in our scope and what's not. And it's our job not to cure these people. It's our job to provide the tools for them to take or leave. And as part of our responsibility as licensed clinicians, we need to be able to recognize that lack of improvements does not reflect on our failure as therapists, but it just reflects that these patients' needs may lie elsewhere. And a great first step is having discussions about these concepts and encourage seeking psychotherapy treatment if needed to address those non-physical components of pain. And hopefully in the not so distant future, we can have, offer a more immersive program like that for our patients that need it so badly in our population here in Jacksonville. But for the meantime, I think it's really important to just, provide this knowledge, provide these tools. And, like I said, knowledge is power for these patients. So just some references. And if anybody has any questions at all for me, here's my contact information. I'd be happy to chat further. Otherwise, I really appreciate you taking the time today, and I hope this was helpful. Thank you very much.